Hello, everyone. Welcome to our seventh session of CME Blues this spring. We're going to talk about Bruno laying bare actions harming our industry. I dare say the most intriguing title of a CME Blues session. Let's go with that. Session sponsored by RedMed Ed. A big thank you to them for sponsoring. Moderated by Allison Kickle, founder and president of Bonum CE. I will turn things over to Allison in just a minute. But first, of course, the reading of our sponsors, my last time for the day. A big thank you to our gold sponsors, Academy for Continued Healthcare Learning, ACHL, Clinical Education Alliance, and Med Learning Group. Our silver sponsors, Academic CME, DKB Med, Haymarket Medical Education, Helio CME, Platform Q Health Education, RedMed Ed, and Talon Health. And our bronze sponsors, Antidote Education Company, Bonum Continuing Education, CMEology, Excalibur Medical Education, Global Education Group, and Infograph Ed. One more page. Iridium Continuing Education, MedIQ, PrimeEd, PeerView Institute for Medical Education, RMEI Medical Education, Vindico Medical Education, and Right Medicine. No truth to the rumor that she's going to change the name to A Right Medicine, so she's not always at the end of our sponsor list. 3 different ways to ask questions. You can text in your questions to 267-666-0CME. You can tweet in your question using the CME Palooza hashtag, or you can use the YouTube chat function. You have to actually click on YouTube, watch it on YouTube. It's on your lower left corner, and you can use the chat function. That's a pretty cool way to do it. We can actually bring your questions right up onto the screen. I didn't think I needed to say this, but evidence has shown otherwise. If you're watching the archive version of these sessions, I guess you're free to ask questions via these methods. There won't be anyone who can answer it, at least immediately. But, I mean, go nuts if that's what you want to do. We've had a few questions on the archive recently. Interesting. Okay. We are not using Poll Everywhere for this particular session, but I did want to give a big thank you to Creative Educational Concepts for their sponsorship of our ARS system for the rest of the session. So a big thank you to them for that. And then the last from me, our speaker disclosure slide. Opinions, discussions, and/or conclusions expressed are those of our panelists and do not represent an endorsement by or position of their employer, its parent company, or affiliates. And so with that, I'm going to turn things over to Allison. Although I need to make a comment, everyone needs to stick around to the very end because there's a rumor that Antonio and Mike might be doing a duet. We don't talk about Bruno at the very end. So good reason to stick around. Allison, over to you.
We should have started with that. It's not creative.
That's true. Good point. Next time.
Well, thank you for having us. I've been texting with a bunch of people today to say CME Palooza truly is just the most valuable, at least for me personally, conference. Take a lot out of it. And thank you for everyone who's listening in.
Thank you.
You're welcome. We are excited in the session to stir the pot a little bit. I am joined by my incredible friends and colleagues, Amanda Kazurski, Antonio Mio, and Mike Bifudo. If you wouldn't mind, I'll call on each of you to do a quick self-introduction. And if you can just talk for a second about what perspective you're bringing, supporter, provider, a little bit of both, that would be great. Amanda.
Hi, Allison. Thanks for including me today. So I am here providing a supporter perspective. However, I am new to my supporter role, relatively new. So I bring a lot of baggage from the provider side and struggle sometimes, as I think through some of these questions that I have a feeling are going to come my way. And I currently work for Pfizer.
Thank you. Antonio.
Thanks, Antonio Mio. When Allison asked me to be part of this, I pretended that I was busy for about half a second, so I didn't seem too eager to join her panel. But I've been in IME CME now for about 6.5 years. I will be providing the supporter perspective from a small and then a medium-sized pharmaceutical company, providing educational grants in CNS, psychiatry, respiratory, neurology, and now oncology.
Wonderful. Thank you. And Mike.
Hi, I'm Mike Bafuto. I assume Allison invited me after she ran out of other people whose names started with A. I am the president at Integrity CE. I'll be bringing the provider perspective. Also sort of held every position in med ed on the provider side. So hopefully I can bring some of that to the table, and happy to be here.
Thank you. So as a quick overview of what we'll be covering today, so CPD, CME, CE is an industry heavily focused on improvement. So quality, knowledge, competence, performance. Yet we believe we often disregard or ignore issues at hand that really stifle the advancement of us as an industry. Some of the problems have been so repetitive that they've become the new norm. And by maintaining the status quo, we damage the credibility of our industry and the viability of our industry, and ultimately we harm the patient. So we've broken our discussion into two main sections that we consider the most challenging: funding and outcomes, and possible pragmatic solutions to these issues. So none of us are prepping for an industry-wide grudge match, but it's really just a dose of pragmatism with a sprinkling of altruism that may be just what the doctor ordered. And I want to give a little caveat too. I am no stranger to controversial topics, but I think if we don't bring them out into the light, how can we ever expect to address them and become better ourselves? So we are going to lay these out in a couple of different scenarios. And the first scenario are the potential harms and hindrances of multi-support. This isn't necessarily a new topic, but I think we have to really address it on the head. So this scenario: you've got a multi-support initiative with multiple activities of varying formats. So this is a big one. Your total budget, or bigger, your total budget for the program is $350,000. You are a medical education company. Your pass-through costs are approximately 65% of your total program budget, so relatively high. Supporter one comes in at $150,000, your full ask amount, in December. So one side note, this is a supporter with an emerging therapy that's not yet on the market, so keep that in the back of your head. You're sending that supporter status updates as well as reaching out to the other supporters for grant review decisions. You've asked equal amounts from a second supporter who would be primary, and then a small amount from a third supporter. The other supporters are non-responsive until mid-February, so a full, almost 2 months after your first supporter came on. And while multi-support's not mandatory, it's highly preferred. So I'm going to pitch the first part of this question to you, Mike. How do you manage status and sort of relationship management with that first confirmed supporter? What do you do in this scenario?
So I think ideally you go back to that supporter and say, thank you for your support. We have X number of grants still out. We've gotten declines from X number of companies, and we have some confidence in some funding decision, a positive funding decision to come through in the near future that doesn't affect the program, right? And that's the perfect world, which multi-support never is. So I think, what happens sometimes is you provide the supporter with that first update after the approval, and then 2 months later, the supporter has to send you a message and say, hey, what's happening with this? And you say, still waiting. And depending on when this activity was meant to start and where this first supporter's product is in the approval timeline, may affect their strategy. But you sometimes end up managing the supporter relationship as well as the supporter's portal, because you have start dates and you have milestone dates, et cetera, inside portals that will prevent you from submitting a change of scope if the activity was supposed to have started. So you end up balancing all of these things, and I think as providers, and especially if you don't have a CRM and you don't have a reminder, a lot of the communication and a lot of the stuff that the I's that need to be dotted and the T's that need to be crossed sort of get dropped until that second supporter comes on with whatever amount of support they come on with.
Great. advice and feedback. And Amanda, I would think this, because you have such hard deadlines with RFPs, this probably happens to you a lot. How do you see people managing it?
It does, and it is a struggle when it comes to multi-funded requests, because you see the value. There's an opportunity to really, contribute. You don't have to put all of your budget or large portion of your budget in this grant. So it makes a lot of sense, financially. Let's try to spread our wealth. But there is a challenge when it comes to timelines, and I think oftentimes there is silence. I don't think there really is that much communication. On a rare occasion, you'll get a little bit of information, once the grant is approved, that you've had either some supporters are reviewing. Sometimes you don't. I think it's actually more often than not, we don't really get much updates. So 3-4 months go by, and then we might hear something every once in a while. I do feel like as a supporter, it's on us to stay on top of it, but that's just one of many grants. So it's very easily for us to get lost. That one just gets trickled down our list until a change of scope comes in, and that's where I think your question really does now impact our decision. Where is the impact of this change of scope in the timeline? Do we want this to take place this year? Is there a chance that it's going to take place this year? Or has everything really been pushed to another year? And is it still what our goals are? Is it still going to be aligned with our strategy? So those questions are really the driving force behind the decisions when these change of scopes are coming in. And I couldn't go reinforce more what Mike was saying. I really do appreciate when someone's proactively reaching out, even as more are declined. If we're waiting on 3 and 1 gets declined, let me know that we're waiting on 2 more. And then, all right, we're down to our final 1. That way I can prepare. I can, communicate with my team. Hey, this looks like it's going to be half of what, we had envisioned. Is this still something that if we come get a change of scope, is it going to be aligned if we think it's going to be strong enough to get our achievements, or our strategies achieved. So,
and I think in regards to communication, it'll be a theme that we carry probably throughout this entire discussion. I think from a med ed company, one of the balances too is you don't want to keep coming back and giving status updates and going, I don't have any information, because there's that fine balance too of it's like when you start a great relationship and then someone has a ton of questions for you, and by the end of it, you're annoyed, even though really no one's at fault. So that's a really fine relationship balance. I'm always like, am I bugging them too much without anything valuable? Like it's this give and take. All right, so the second part of the scenario, and then we did get a question we'll address in a second, is supporter 3 declines. So let's just say supporter 3 and 4 scenario. Supporter 2 commits $25,000. So, a very small amount compared to the original ask. And they support in April. Only after you say, listen, I've got to pull the grant request. I've got to produce something. I've got to build a change of scope to go to the other supporter. So Antonio, I'm going to give you the very uncomfortable position of speaking as supporter 2. What are your expectations at this point from the provider?
Yeah, I think to your point earlier, the communication, I think there's probably a very good reason why the grant sat with me for so long, whether it's a matter of funding approvals, depending on when we get grants. I work now for 2 Japanese companies, and our fiscal years are April to March. So we're not aligned with other supporters who may be January to December. So there could be a litany of reasons why it's taken me so long to be able to respond. I think the expectation of, okay, I approved the grant, now understanding as quickly as possible that we appreciate the support. We didn't get what we needed, or what was proposed, or what was asked for to be able to complete what was proposed. And knowing that rather quickly, I think, is really important. And then getting an understanding of compliantly, is your intention to submit a change of scope? Or are you do you need time to assess to say, we can't accept this funding at this point. There's no way we can conduct the education and meet the objectives that we were outlining with the support that you gave. But knowing that sooner rather than later will help us plan. If this was a very specific tactic that we were looking to achieve certain objectives, to meet certain goals, do we need to look for a different grant, or are we going to be expecting a change of scope? So again, just reiterating that communication as quick as possible.
Okay, so we have a question that came in. It's a good one for Amanda and Antonio. Does multi-support versus single support impact your ranking of a proposal?
I guess I get the luxury of answering first. I think for me, what would help rank it higher is if there's details in the proposal as far as a contingency plan and or where it currently sits. If partial support has been secured and there's 2 additional supporters, us being one of them, I could see it helping rank it higher, again, for the concept of spreading my budget more. If I am a part of this multi-funded request, that might give me another chance to support another program. So for me, I can see value in multi-funded as long as I understand the current status when it's coming in, and what the contingency plan is if additional funding doesn't come through.
Yeah, I agree. I think, I don't know if it ranks it higher necessarily, but it's something that would be looked at. I think compliance teams definitely like to see multi-support. I think from external perspective, from a learner, seeing multiple names guarantees that it won't be a commercial. Not that anyone wouldn't be fair and balanced, but knowing that multiple supporters are contributing to this, I think also just kind of reaffirms that, not just for the learners, but also for audit purposes. Anyone, if people like FDA are walking around, just seeing a lot of names, I think is really good perceptually. I think it's always welcome. I think if for symposia and national congresses, I think we'll get to that later on in the conversation as well, I think really welcomed. But ultimately, if it's education that I really spoke to me, the grant itself, I think it's really going to be high quality. It's not going to stop me from supporting something that's sole support.
And remember, one of the supporter 1, doesn't have a therapy on the market, so that might make this a bit more dicey. Mike, you had a comment you wanted to bring in.
Yeah, so I just first would reiterate Amanda's comment about the contingency plan and the grant request. I think is the best thing we can do proactively as providers to deal with this. And I think we've all had the scenario where we have half support or 75% support, and we're waiting on a decision from a provider that we know that has said we expect to, this is going to committee on such and such date. And the expectation is that we'll fund it. And you think it means we'll fund it for what you need, what's left, and what you get is $25,000. So you're back in the scope change status. And one of the things that has come up for us in these situations, and especially from my partners who really don't know anything about med ed at this point, and essentially our business partners, is why don't you report or disclose the supporters on a tiered level and say the one that gave us $150,000 is gold and the one that gave us 25K is tin or something like that. And in these situations, providers, we're generally like, sheesh, man, you're giving us a hard time. And I think the thing that prevents us from doing that is, number one, I don't think the supporter that provided 25K, that provided essentially what they could, wants to be sort of put on the lower tier. And number two is, do we create a perception of bias for that supporter who gave more money just by virtue of the way we're disclosing their support? So it's, there's a double-edged sword there.
and I know that fair is not reality, but sometimes I do feel like it's really unfair because supporter A came in early and they provided a significant amount of funding, and then somebody else comes in less and they basically get the same benefit. Sometimes that's hard for me to deal with in feeling allied with all the stakeholders on my program. So that I think that's a tough scenario. And I think, in conclusion on this one, communication and clear contingency plans. But I have a little question on the contingency plan. Have you all ever heard of a supporter who has an issue with a contingency plan? If you say, curriculum development costs X, these 3 formats cost Y. Have you ever heard of a commercial supporter saying that is them selecting the content in some way by putting the amount and can you have too specific of a contingency plan?
Yeah, I have heard supporters say they prefer not to see the contingency plan, knowing that if they supported a certain level, the concern is that they could be directing which portion or what content gets developed. I think my perspective, I become much more comfortable with contingency plans, especially during times of COVID. I don't know if it needs to be super specific, and it also still relies on the provider, their faculty, to make the ultimate decision with the funding that they receive. But it does help me kind of assess, okay, if they don't get full funding, at least some type of activity will be launched at some point.
Okay. And then can providers say, here's our hard date that we need a decision by? Would that be effective at all? Would that have an impact if they communicated that with you after a grant was submitted?
Mm-hmm. I think so. For me, we work on a little different model because we use the RFP model. So our hands are tied. I think one of your first questions to me was with your RFP model. Our RFP model does make it challenging for providers who are tending, to do multi-funded support, be it the nature of the therapy area or whatever the case may be. So that model does make it a challenge for providers. But I think from my perspective, our seeing a timeline in there is helpful across the board, because then I know potentially when others might be making their decision, and our decisions basically will be made by our timeline set.
Allison, I think the reality for providers too is we're not going to return money if it's supported after a due date. One of the things I thought about in preparing for this is could we say there's a minimum funding threshold? Essentially, if you give us less than $75,000 or less than $50,000, we won't accept the approval. And would that be compliant?
So,
I have a question, or at least a thought on that. Again, this is me wearing both hats now. When I was on the supporter or the provider side, I understood, the angle of the one organization providing $150,000, and this one's only coming in with 25. And you're like, well, how do I justify it? But I guess the question to me, even then, but more so now, is why does it matter? Is it really that important? From me, when I'm approving a grant, I don't need anyone to know how much I approved, of that grant. If there's all of, 6 other supporters, am I 1/6 of it? Am I 85% of it? I don't think that makes a difference. The fact that I thought in our, organization, our committee thought that this was strong enough to submit and approve any amount of money for should be sufficient. For me personally, the fact that our name is on there is enough. Do I think a $10,000 approval just to get my name on something is, a game to play? No, I don't. I don't think so. I know that there's been a lot of multi-funded programs recently that I've seen. I'm like, oh, I wish I, could have been part of that. But our model, our RFP model, prohibited the submission to us because it just didn't fit. So now Pfizer's not included in, in that activity, which is, oh well, that I'm not going to go ahead and write a check for $10,000 just because we want our name on it.
I think, Mike, to your point, I think the other the thing to consider is where that supporter is in the educational timeline. If they don't have an approved product and they're just coming in disease state, MOA of therapy, their budgets may not be able to support more than that. And even if they really like that education and they want to get it off the ground, they could say, like, look, for the year I have X amount of dollars, compared to supporter A, who's been in the space for a long time and might have 3 times the budget and can support that. So I think that's the only worry, is phasing people out unintentionally, when they could say, I want to support this. Also, seeing the outcomes from this education will help me advocate internally to get more funding.
Yeah, and Antonio, I think that's the responsibility of the provider. If you're doing something in a general disease area and you know that one supporter has 90% market share in it and the other has a much smaller pool of patients, or an investigational product or something like that, you've got to be aware that the levels of available support are going to be different. So
I think, the communication goes both ways too. So I have gotten calls before that say, we're interested in this program. It's coming to review. There's no way I'm going to be able to support it. If it does get approved, there's no way it's going to be at the amount you asked. That, whether you can do it or not as a supporter, but it gives me enough of a heads up to start working on plan B so it doesn't delay any further. Because even if a contingency plan is written in a grant, especially I work a lot in oncology, everything shifts. So it changes very, very quickly. So if something changes scope, 4 or 5 months later, a month before ASCO, that program might look a lot different than the one I submitted in the fall. So I think a two-way communication, the pendulum and the iron curtain, it swung back, right? So if we can just have it go both ways, so as much as can be compliantly shared, so we can mitigate any of the negative effects of multi-support is welcome. Okay, so second part of this scenario, the provider that was funded at $175,000 of the $350 total budget submits a change of scope that reduces the program by about half, but it'll achieve all the originally stated learning objectives, the agenda, the content outline targets, and the outcomes as planned. Okay. From the supporter standpoint, what's wrong with this scenario, and what's your perception of it? We'll have you go ahead first, Antonio, since Amanda went first last, please.
Yeah, I think one of the concerns, one, getting it, and then I could share a concern that I think I've done as well, is when we're getting change of scopes, I think we really would want to see a better analysis of what was originally proposed. What are the needs being identified, the gaps in practice, the objectives that are being proposed to meet that, and then the type of educational intervention. We oftentimes see change of scopes that will gut a program with what seems like not a lot of thought, other than this is the budget that we have, we're going to try to get something off the ground. And I think it's important that we don't look at a change of scope as a rescue document to say, hey, let's just try to get something going. But I'll flip it on myself as well. Sometimes I will get a change of scope. This looks absolutely nothing like what the original grant was. But I shouldn't be afraid to review that and embrace it, to say, okay, they're still trying to keep the objectives intact. They're still trying to meet the gaps that they have identified that I agreed with originally. So the intervention may look a little different, but if they're still going to do that and have an impactful reach, that should be okay. I've gotten change of scopes where I'm like, this isn't what we talked about. No, I can't do this. But really analyzing it, discussing with the team, like, this is still going to have an impact. Can we move forward?
Good point. Amanda, do you have anything you wanted to share?
No, I agree. I agree with your comment. I do think that in that sense, the scenario that you shared, I would question what was, contributing to the budget in the first pass, for them to, come through with this modified program, which seemed to be, pretty much aligned to what they were doing. So I think that to me would be really looking closely at the budgets and wonder, how are they doing it? But if the end goal is still there, if the learning objectives are aligning and the means by which they are going to accomplish that, does pass our, review and critique, then I think it would be okay.
Right. And I know, I come from the perspective of a very niche sort of boutique, tiny provider. So I might have different latitude than the larger companies. But if a supporter is willing to have a discussion with me about the proposed change of scope and my rationale behind it, I'd like to have it, because it's not cookie cutter, it's based on timing. It's based on, where things are in the market. It's based on, if it comes 4 months later and your business is incredibly busy at that point, like executing within the original timeline might no longer be possible. So I think that there's a lot of different things that go into it. I think one of the things that we see on both sides, so kind of sins committed on both sides, is a lack of understanding of the process, or maybe what goes into developing the grant proposal or these budgets. And the fact is the entire industry is a capitalistic enterprise. So no one's trying to do this at a loss, but then there are some examples out there of folks who are doing things at a loss because they can either offset it in other places. And I want to put the stake in the ground is that really should be the exception rather than the rule. And I also understand, if someone can do it on a reduced budget and that gives you more latitude to do more, I wouldn't blame you at all either. So I think, from a change of scope standpoint, that thoughtfulness that goes into it and that honesty and rationale is really important. How many of you all see the first thing that gets slashed is the audience generation fees? Do you see a change in learner numbers, or do the learner numbers stay the same?
I think that, so Allison, as you just alluded to, developing a grant request is hard, right? And I don't want to be like the woe is me. It's hard for us to develop grant requests, but there's medical involvement, identifying needs, sort of doing intelligent educational design agendas, et cetera. When we have to do a scope change, we don't want to gut that part of the program. We really want to keep the content, the needs we're going to address, and the outcomes we're going to achieve through the activities we're going to do the same. And the unfortunate reality is hard costs, large hard costs. So the first and the easiest things to cut. Mm-hmm. That's things like audience generation, digital development, graphic design, sort of heavy interactivity and on-demand programs, those sorts of things. And cutting that allows us to achieve the objective of addressing the needs we identified, achieving the outcomes we sought to achieve, just for a smaller percentage of or smaller number of learners, or through some methods that are different than what we had originally intended.
And if people are using the metric, your cost per learner might be exactly the same as it was for the original proposal, because the reduced funding, and you reduce your learner numbers and that becomes same, your net zero. And Mike, I want to harp a little bit on a point that you made at the beginning. We hear on the med ed company side a lot about, no typos, no this, no that, no, don't do this, don't do this, don't do this, don't do this. And I agree, 100% agree. But I, for example, design a unique art cover page for every single proposal I do, unless it's templated. And then when that proposal gets declined and I don't hear anything, I'm like, oh, I just donated a part of my heart and my brain to you. And nothing, it feels, so I think we can have both an understanding on both sides and a tolerance on both sides for the balance of volume business and focus and care. So just an understanding. Okay, we had some questions come in. And
Allison, I want to chime in on that real quickly. From my provider experience, I think one thing that you as providers are skilled at is being able to use resources. There's several ways to produce a program. You can use, bells and whistles, some more high end digital, or you can scale it down and still end up with a great quality program. And I think that's what is, at least in the back of my head, when I'm looking at proposals of how much of this is still the essence of what we want to do. And I know that with a different potential partner, audience generation partner, you can still reach your goal. Or if you're working with a different vendor to do some sort of web development or execution of a program, that the end piece is still going to be there. They're just a lower cost option. So I know that I think that providers do that well. And I have to, always keep that in the back of my head of what's going into that reduced scope budget.
Yeah, just to I know we have questions, but going back to what I was saying earlier as well, like I know that's probably the low hanging fruit, but when you're working in some areas, like if we're trying to reach community oncologists, for example, that are very difficult, this group to reach in general, and you tell me, oh, I'm just going to not do audience generation, that's a red flag for me, because I don't want to see a heavily in-depth oncology program that is going to reach 5,000 PCPs. Great that they're engaging. They need to know this as well. But when my expectation is that this program is going to reach the oncologists, and then that audience generation to reach them was the first thing cut, that makes me go, okay, let's think about this.
Agreed. 100% agree.
And I know, Allison, we're going to address this with questions in a sec, but I, as a provider, never consider cost per learner. I think it's a black hole that will lead you to sort of bad educational programs with bad content, with the wrong audience, to achieve a metric that is generally meaningless in terms of educational outcomes and what we're trying to do as an industry. So I avoid it.
I'm looking for the clap emoji to go. I completely agree. I feel like, and two, when it's in the proposal, it's sort of monopoly money. Like that, what's that number per? Does somebody say unique viewer is that number, and then they calculate it that way? I mean, that's so skewed. We'll talk about this in the lightning round, but like patient impact. Can we put that one with patient impact, like over here, and close the door, lose the key? Let's address some of our questions, and then we're going to jump around in our schedule a little bit and talk about outcomes and learners in more depth in a second. And then we'll go back to RFPs. So we got a question about the threshold for requiring a scope change. Is any change considered a scope change, a significant change? And this is, very subjective. A format change, a date change, all of the above. What's considered a scope change? Not considered a scope change.
Yeah, for me, I would say date change for sure. Because that's in the system and that triggers everything going forward. So date changes, I like to see as a change of scope. If it's a couple days, it's not a big deal. But if we're moving the program and then your impact reports are going to be impacted, then I think it's important to go in there. Format change, yeah, I definitely think I need to know when a format is changing. So those are for me key drivers.
I actually date changes for us or for me is not a requirement for a change of scope. We know that the target date is a target, and it depends on funding. It depends on when you get an LOA from us, if it's sole support, if you're looking for other supporters. We will request something more formal if it trickles into the next fiscal year. But essentially, I think a good rule of thumb is anything that changes what was originally proposed in the grant submission drastically. So if it's a format, if even something like number of faculty, because that impacts the budget request that you put in. So something like that as well is good to know about. But I think something that changes the I think I used this word already, so sorry, essence of the original proposal should be kind of formally notified.
I think sort of rule of thumb for me, just in general, is any change to the learning objective, even if it's minor, I usually send an email and say, does this require a formal change of scope or does this email suffice? I mean, there are a couple of things. Anytime there's a reduction in program or the program scales up, and usually if you're in a situation where the program scales up, you just get, it doesn't require a change of scope, but that looks great. Awesome. But if there's change in faculty number as well, I usually submit, because that's a hard budget line item I see that's a sensitive budget line item. So those are a couple things. And I think an easy thing, again, back to the communication that we can probably do as providers, is send that email that says, do you need a formal change of scope? Does this email suffice? Because it's going to be different by every single supporter. And unless you're working with the same supporter regularly, that's going to be a tough one to nail down. So do yourself a favor, send that email. Okay. We're going to move into outcomes. And sorry, this one's going to be a little bit of a pile on, and we've touched on some of these things. And we'll also talk about, we got a question in regards to change of scope, shift in cost per learner and perception. We'll sort of touch on that. We already have our, but so an awarded grant proposal has a Moore's level 5 self-reported change in performance outcomes goal. The learner estimates were slated as followed: 500 specialists per activity, 2,000 total specialty learners across the program. So we're looking at sort of this as the guarantee on learner. Antonio, I'm going to kick it to you because you're in oncology. When you see that number, what do you think? And what do you think about the level 5 performance?
You set me up for that. I think 500 specialists doesn't raise any flags until you tell me you're going to get level 5. I think for true level 5, that is not intent to change, but actually tracking practice change as it's written, I think takes more focused education, smaller groups, module-based or curriculum. And if you're getting 500 specialists, in this case oncologists, for each of your, I don't know if you said it, how many per activity? 4, I guess. You can have my grant funding. Essentially is what it comes down to. But I will look at what's being proposed to level of outcomes and knowing the space that we might be in. I think that's a realistic number, maybe in something that's like a PCP audience. But once you start getting into these specialties, it would definitely make me question what is the action. Are you over promising and only gonna under deliver?
And then Mike, okay, so I'm going to give you this perspective. Your business development or educational strategist comes to you and says, well, I've been told that my guarantees are too low. They need to be higher. So I really need to stretch this. If I'm going to have any chance of getting this grant, we'll figure it out later.
This is where the we don't talk about Bruno comes in. So I want to touch on the performance outcomes. The session earlier today, I think, was 32% of people said every activity should measure performance. Is that right? So the ACCME for commendation requires 10% of your activities measure performance to meet that criteria. So I think every activity is an outrageously lofty goal. And I think that calling subjective self-report of the 5 or 10 follow-up survey completers you get 6 weeks later, a representative sample of a large audience for performance change is ridiculous. And I that's my soapbox for my provider colleagues. I wish we would stop doing that. Allison, to your question, I've had that, right, where we do a quarterly report and we're at, 45% of our audience goal. And the supporter says, my other providers are at 85% in the first quarter. And I know they're using the same distribution platforms as me because we're generally all using the same distribution platforms. I feel that we're creating an environment, and providers are doing this to ourselves. We've created the expectations with supporters, even if a supporter's expectation may be 10% elevated. We've created this sort of expectation that we're going to reach these, like, these enormous specialty learner targets, and what probably ends up happening is we underdeliver, or we get we get sort of internists with a subspecialty, or relying on like polling data or survey responses to sort of represent them as specialists. And it's a problem, I feel like, for us. And I think we've all gone to like a session where we see an end of like 50,000 for a specialty, and you just go like, there's only 5,000 of those specialists in the U.S. So who are all these people? And it's something that I think is a real issue.
Okay, so that pulls into the next part of this. So provider sends over quarterly metrics, and they look low, but it's early. So when do you, as a provider, when do you, as a supporter, hit the panic button? As a provider, are you honest with any challenges that are going on with the design, guarantees, flaws, or do you stick your head in the sand?
So I'll just answer that quickly. I've never had a supporter who I said, we're not tracking where we want to be. We're doing what we can to address it. This is what we have planned. We hope that when we report on this in the next quarter, that it looks better. I've never had a supporter say, that's bad. They all say, I appreciate you being proactive about it, and we look forward to the next report, right? So I think if providers do that, we're in better shape.
Amanda, any comments, or Antonio?
I agree with Mike's comment. If you come with, we understand that it's low, but we're doing X, Y, and Z, then I think it's great. Oftentimes, we don't get updates until the end. It recently changed now that we are going to start looking for program updates, but for a long time, we would just wait until the program was done to get a report, and that can be problematic.
Yeah, I mean, to answer your question, I think coming with a plan helps overcome that, and acknowledging that it's not. But to answer the way the question is reading is, the panic starts immediately. I think, especially in a space like oncology, where data is being generated so quickly and becoming outdated within 6 months, that program may no longer be viable or relevant, even if it's getting updated. And I think since I've started in CME, we've heard it, 4 to 6 months is your largest uptake of participation. And with COVID, especially, the amount of content and education that's being supported is growing at such a fast rate that they're already moving on to the next educational program. So if we see something within the first 4 to 6 weeks that has very low participation, appreciate the willingness to try to drive, but within 6 months, learners are moving on.
I'm an advocate for a 6-month certification period for rapidly evolving areas. There's really no need, and it doesn't probably cost about the same, but still, I mean, you put effort into it. Derek, looks like you want to pop on and say something.
Yeah, sorry to interrupt. Just a quick update. I got a note from Scott. Our next session is going to be delayed by about 15 minutes because 2 of the participants are under a tornado warning. So as much as we love CME Palooza, it's probably better to let them go where they need to be. And so we'll plan on starting at 4:15. It also means, Allison, you can take a little bit extra time if you want to answer some of the questions and whatever extra you have. So we don't need to have that hard stop at 3:55.
Okay. Well, we're getting a lot of good questions too, so that's helpful. Thank you. We got a question in regards to the expectation for the goal of 500 learners, all being level 5. That's really interesting because I've never actually thought about a proposal segmenting out your recruitment and your outcomes stratified by, level 5 will be evaluated on 50 learners or whatever. I mean, I think if you're doing focus groups, that would be really interesting and valuable to be transparent about how you're utilizing that strategy. Have y'all ever seen anything that's segmented like that in a proposal?
Not in a proposal, no.
No, that might be a question related to sort of my comment that you're taking a small set and using it as a representative sample size. And it's a really good point, right? There's some gray area there. And I think if you can show performance change in 5 HCPs, that's valuable. I think if you can show performance change in 1 HCP, it's valuable. So more power to you.
And Antonio and I have already brought this up. Well, Antonio, you brought it up, but I second it, that self-reported changes in performance, this is my personal soapbox, that's not performance change. That's not a level Moores, traditional Moores level 5. I think that's a big sin we're committing, is by redefining that as something that it's not, that we're making the things that truly are level 5 way too expensive from a perception standpoint compared to the other proposals, and we're watering down the education and things that aren't truly there. So, sorry.
Yeah, and just to I think there's value in intent to change. I think where even evaluating it internally and speaking with stakeholders who are providing funding, if I do an aggregation of education over a year and I say, oh, there's 10,000 learner HCPs who said that they're changing practice when really we're talking about intent to change in a population of 13,000 oncologists, someone can easily say, like, great, we moved the needle. Thank you. Do you need to do all that education next year? I think there's value in intent to change if we're finding what that insight actually means and conveying it properly. They're saying they're going to change. We still need to continue to educate to make sure that just because they said it, they're actually doing it and sticking with it. And that I think is the more important metric from the intent to change versus we followed up with them. We saw EHR polls. We saw prescribing patterns, or prescribing patterns, but guideline-based care is being impacted. That is performance changing, and that I think is a smaller percentage of that 500 to really be able to say they changed practice.
And then looking at, if we're looking at this long term, is if changes didn't occur in the way we anticipated, why? What are the because it's not just a single, like, we could spend a lot of money on research in this field. Okay, another good question came up. How do supporters verify that a provider learner counts are being defined the same? How well are providers following the OSP? And I'm going to add a secondary part B of that question is, how many supporters have bought into the concept of OSP and are actively evaluating grants against that metric or that framework? Who wants to go first? Bruno's sitting in the back of the room.
I'll start. So I do think, just following up on your comment, I don't know how many supporters across the board have adopted that OSP definition. I know some have been very vocal and adopted it, and others have not. I know what I look for is, what is your definition? If you tell me what your definition is, in the proposal, then that's going to help me know exactly how to compare, this proposal to another one. I think providers are getting better at doing that. I do think the explanations in the proposal on who the audience is and what the learners are versus a participant, I'm seeing it so much more frequently now. It actually broken down and them defining whatever that metric is. Is it an OSP definition, or is it their own? I'm fine with whatever they choose. I just want to know what it is so I can understand when someone is saying they're having 20,000 participants and this one's having 2,000. What exactly is your definition of a participant?
Well put. All right. Okay. And I think the reality is all this level of thoughtfulness, both on you looking at that at an individual level, and then tracking it on an individual provider-based level throughout the program, or providers looking at each, program, therapy area, format. It all does cost money. So I think the value of thoughtfulness and communication is definitely there. And we just have to be sure that we're all maintaining coverage. I think financially for it, I think we're overly optimistic as an industry on what we think we can accomplish for the amount and the time. But I think an extra dose of thoughtfulness is welcome. Okay. And Amanda, you said something I want to touch on real quickly. Separate sets of questions when you have a multi-group audience. You had mentioned you had seen in past potentially like that being segmented by learner type for a program that went out to lots of learners. I think this is a brilliant idea. Can you expand on that a little bit?
It's so such a huge of a novel idea that it's not that hard to think through actually, but why isn't it being done? Because we've kind of touched on it. When you're using distribution partners, you know that a large number of those partners are going to drive a mixed audience to your program. So it really would make sense to have tailored questions based on those attendees. And you don't have to have 6 different, demographic type questions, but if you know that one is a specialist, let's say oncology, you have oncology type related questions that are related specifically to the clinician, the physician. And then you have maybe, scaled back versions for all other clinicians. It's a great way to see the impact. The fact that you're educating these other clinicians who may be interested in the topic and want to learn is great. And for you educating them on adverse events or side effect management, wonderful. They might be, they're still seeing those same patients. Do they need to have the knowledge that the oncologist or the specialist needs to have? No. And are there metrics going to skew your data? Without a doubt. If you put everyone in one aggregate pool, it's going to skew your data. And I don't think that they should not be included in the data. So having a question that's really more aligned to their skill set makes for a nice, robust outcomes report. I think there's different ways to do it. I think people have or could, just maybe the statement is providers tend to pull them out. So, if they're doing an outcomes report, they might only focus on the oncologist, and that's how they're segmenting the data. So the report is just going to be focused on the oncologist. And at the end of the day, really, if it's an oncology program, that's what I want to see. But I also think there is a lot of really useful information in that other data set. So it should not be thrown out, the baby with the bathwater. I think there's data there. And, from this side of the table now, that data, whatever you can give me, is really powerful. And something that a provider might think is not important really might go a long way on the supporter side.
And then, when you're doing your analysis later, you can save some costs there by pulling those outcomes results and not having to split them out manually. Okay, we're going to move into our lightning round. Antonio, I'm going to put you in the hot seat first. We didn't get to our bigger topic, RFPs, but what are we doing well and not so well in hyper-specific or narrow RFPs?
Yes. So lightning. Okay. I think it's kind of all over. We see varying formats being distributed. I know my current team, we are constantly analyzing what we're producing, trying to figure out what is compliantly okay to publish, while also making it worth the effort for us to draft and develop, and also valuable for the providers to read through. I think, the question I've always had is what's different from an RFP that's very detailed compared to driving and recommending certain tactics. I think better definitions may be helpful for everybody. I also have seen very limited information being shared, and I'm not quite sure how valuable it is to the provider. I haven't been on that side of the wall, but I think it's just a balancing act. What's your organization's comfort level and the information being shared? We are doing the best as we're developing it to do our own needs assessment, practice gap analysis based on our disease state areas to put together our objectives that we're willing to support in areas that we have funding in.
Okay, thank you. Okay, Mike, you see financial support continually going to same, more of the same provider, same tactics, same audience, same supporter. You just see a churn. Hot take.
Hot take. I'm hoping lightning strikes me before I have to answer this.
Sorry.
No, I think we're being asked to innovate, and we feel, I think collectively as a group of providers or an industry, we're being innovative in what we're doing. And then we see sort of the same programs get funded. Symposia with case-based symposia with interactive questions, which are valuable for sure, but they're also really expensive. And we see other formats or feel there's other more innovative formats out there that are more beneficial. I think, just going back to the RFPs, one place where, this especially shines is in RFPs. We've been included in a number of closed RFPs that are only sent to a small provider group. I think as providers, I much prefer those. I don't want to get an RFP for something I have no chance to get, because we're going to, there's a chance we're going to respond, and it's possible that the supporter is going to get 100 responses and 99 people are going to end up with declines. So, I guess that's something that providers sort of see. And I think as providers, we all could be a little bit more variable in what we're doing. And instead of just going back with something that was funded last year and had good outcomes, looking at something different that hits a different set of learners or a different group of learners in the same specialty, or something like that.
Good points. And I can understand if it's broke, don't fix it. If it's not broke, don't fix it. But at the same time, if we're going to continue to push things forward, we're going to have to change and evolve. Okay, Amanda, outcomes templates that are mandated potentially to providers that are very specific. Okay, not okay, gray area.
I think it's a very gray area. I think I understand now how important it is to be able to have those metrics in the system. And by using a template of some sort, those metrics are going to be super easy to pull, and it will be incredibly helpful to the grant manager, grant officer, whoever it is, when trying to get a summary to their stakeholders of, over the past 12 months, this is what we've done. However, I also feel like it pigeonholes providers. I think it forces them, to maybe, go down certain tracks or paths. So I have mixed opinions on it. I do think that there's value, and I really truly understand why the template is there. Sometimes I can see it being, a pro, but I can also see it being a hindrance as well. And I know, for providers to go ahead and do those templates for 6 different supporters on a multi-funded program is time intensive, and everyone has different needs. So that just puts more burden on the provider, which therefore puts more burden on the budget. And it goes back to what we were starting with, our very first question of what happens with the change of scope. Well, who is the supporter, and what does their outcomes templates look like?
And nothing, I think what we've also come to over the years is that things aren't black and white. There's rationale for all of it. And I think people are generally very well-intentioned in their approaches. So communication, transparency, understanding, and tolerance, good life lessons. What I'm teaching my kids, maybe. All right, Derek, I think we are out of time. So thank you for the platform. We appreciate it.
Sure, and thank all of you. Great session. That was awesome. Great discussion. I'm sorry that we've run out of time, and Antonio and Mike can't do their duet. We'll have to save that for
I was ready.
next time. I know, next time. Maybe we could have CME Palooza the musical, and then you guys can be part of that. So again, thanks everyone. Oh, I have to bring up my slides. I distracted myself from that. So just a reminder that we do have our survey. And so if you have a moment, you can take that. That would be great. It's on the live page. And so for our next session, Fade Out HIV, connecting Black barbers, their clients, and community clinicians. I mentioned before, but I'll say it again, slightly delayed. I think they're looking for a 4:15 start because of tornado warning. There is a potential that the tornado warning gets extended. If that happens, we'll try and put up a note. We'll just have to move the session to another day and do a whole separate. Which, hey, always up for doing CME Palooza, extended CME Palooza. So we'll try and let you know. So our priority, of course, is the safety of everyone and not our little conference. So that's totally fine, but we will let everyone know. Thanks again, Amanda, Allison, Mike, and Antonio, and we'll see everyone soon.
Thank you. Have a great rest of your day.